Hello friends, this is my second lecture on general anesthesia. Now I am going to talk inhalational anesthetic agents. Hope all of you have gone through my previous lecture on general principles of general anesthesia. If you don't, then kindly go through my previous lecture on YouTube and you will get some basic idea of general anesthesia, how it works, history, then what is MAC, blood gas partition, oil gas partition coefficient, mechanism of action of general anesthesia in general, as stages of anesthesia, elimination of a GA, and second gas effect and diffusion hypoxia. To proceed further, all of you should know anesthetic protocol. The safe effect of anesthesia cannot be achieved by any single anesthetic agent. Therefore, combination of many drugs are given to the patient to produce desired effect under safe limit. It comprises of pre-anesthetic medication, induction of anesthesia, maintenance of anesthesia, analgesia, and other drugs which includes to reverse neuromuscular blockade, to prevent vomiting, to reverse residual effect of opioids and benzodiazepines. There are two types of anesthetic agent. One is inhalational, it is mainly used for maintenance, and another one is intravenous for induction and short procedures. Now coming to classification of general anesthesia, which I have discussed earlier in earlier lecture, that it has been classified into two wide groups: inhalational and intravenous anesthetic agents. In inhalational, there are three types of agents are used. One is gas, volatile liquids, and halogenated hydrocarbons. Another one is intravenous, where we can use fast inducer agents, slow inducers, and neuroleptic analgesic agents, dissociative anesthetics. Now coming to induction agents of general anesthesia, when we induct a patient for a general anesthesia, we can use propofol. It is very widely used because it is easy to administer, quick recovery, and lacks of post-operative nausea and vomiting. Another agent is inhalational agent like sevoflurane, which is mainly used with combination with nitrous oxide and oxygen. It is mainly used due to its property it is non-irritant to airway, rapid induction, and there is minimal side effect. But it has more post-operative nausea and vomiting sensation. Thiopental sodium is another one, midazolam, etomidate, and ketamines. When we talk about the speed of induction of inhalational agent, the disease state of the patient can be affect speed of onset of anesthesia. The faster induction happens by the high minute ventilation. When patient is in hyperventilation state, then induction is faster. Then lower functional residual capacity in restrictive lung disease, and high fresh gas flow. And the slower induction happens by high cardiac output state like anemia, hypothyroidism, and pregnancy. And another one is the high lipid solubility of the inhalational agent. Now coming to today's topic, inhalational anesthetic agents. Inhalational anesthesia refers to the delivery of gases and or vapors to the respiratory system to produce anesthetic effect. There are many techniques used to administer inhalational anesthesia. The simplest one is the one drop method, which is only used for ether administration. Now coming to another techniques for the inhalational anesthesia administration, it is achieved through the anesthetic machines. First one is the open system. When patient is allowed to exhale the inhalational anesthetic agent into the open space, and second one is the closed system, when the closed loops are connected to the patients and no inhalational agents are exhaled into the open space, but it is allowed to rebreathe to the patients for achievement of better anesthesia. And second one is the semi-closed loop system, when partial of the anesthetic agents are allowed to exhale into the open space and partially allowed to flow into the closed loop system to the patient for rebreathing. Now coming to anesthetic machines, it is known as Boyle's apparatus. It has the gas source, either piped gas or the supplied in cylinders. The diagram shown in the cylinders, there are carbon dioxide cylinder, nitrous oxide cylinder, oxygen cylinders, and also there are the cylinder pressure gauge, knobs, then flow meters, vaporizers, and another one is the delivery system or circuit to the patients. Now friends, when we talk about the desired physical properties for inhalational anesthetic agents, it should be stable in light, environment friendly, non-inflammable and non-explosive at room temperature, liquid and vaporize at room temperature, that is low latent heat of vaporization, stable at room temperature with long shelf life, stable with soda lime as well as plastics and other metals which is used in anesthetic machines, cheap and easy to manufacture and store. The another desired biological properties for the inhalational anesthesia, it should be pleasant to inhale, non-irritant, induce bronchodilation, low blood gas solubility for the faster onset of action, and high oil water solubility for its high potency, minimal side effects on other systems, example cardiovascular system, respiratory system, hepatic, renal or endocrine. It should be safe, no biotransformation. It should be ideally excreted in unchanged form via lungs, non-toxic to operation theater personnel. The advantage of inhalational anesthetic agents are the depth of anesthesia can be controlled, very minimal metabolism, and excreted via exhalation. This graph is showing the year of introduction of inhalational anesthetic agent into the market. The first one is the nitrous oxide, which was introduced in 1846, then ether and then chloroform, and in between 1920 to 1919 there was various inhalational agents floated into the market, but later half it was taken up by the halogenated inhalational anesthetic agents. Now, as we discussed, the inhalational anesthetic agents are of three types: gas, volatile liquids, and halogenated hydrocarbons. When we talk about the mechanism of action of inhalational anesthetic agents, the GABA A receptor and glycine receptors are potentiated by fluorinated anesthetic agents, and neuronal nicotinic receptors and 5-HT receptors are blocked by fluorinated anesthetic agents, and nitrous oxide and xenon, which inhibits the NMDA receptors. When we talk about the individual inhalational anesthetic, nitrous oxide is also known as laughing gas. It is a potent analgesic but weak general anesthetic in action. It is colorless, odorless inorganic gas, sweet in taste and non-irritating, non-inflammable. Rapid onset and recovery. It does not depress respiration and no muscle relaxation. It is ideally given as carrier and adjuvant with other anesthetic agents in combination, like 70% of nitrous oxide, 25 to 30% of oxygen with halothane 0.2 to 2% in combination. It is used for dental surgery, obstetrics, post-operative physiotherapy, refractory pain in terminal illness, and maintenance of anesthesia. It is least hepatotoxic, non-teratogenic, lowest chance of bone marrow depression among all of the inhalational anesthesia. And the diagram is showing the blue color cylinder is of nitrous oxide cylinder, and the blue knob is showing the nitrous oxide knob. There are many advantages for the nitrous oxide. First one is the non-inflammable, then non-irritant, rapid induction and recovery. It is a potent analgesic, then no post-operative, intraoperative nausea and vomiting sensation, non-toxic to liver, kidney and brain. There are various disadvantages also. It is not potent alone, so it should be given in combination. There is chances of hypoxia. It inhibits methionine synthase. It is precursor to DNA synthesis, and it also inhibits the vitamin 2 B12 metabolism, causes megaloblastic anemia. Dentists and other healthcare personnel are at risk of exposure of this nitrous oxide. Then gas filled spaces are dangerous. Nitrous oxide may undergo degradation by interaction with vitamin B12 in intestinal bacteria. This further leads to inactivation of methionine synthase that is required for synthesis of DNA and protein synthesis, resulting into bone marrow suppression, which further leads to anemia and leukopenia and megaloblastic anemia. This effect occurs on prolonged more than 6 hours and or repeated exposure. Due to this reason, nitrous oxide is not infused for long-term analgesic effect as a sedative in critical care settings. Another type of gas is cyclopropane gas. It is cycloalkane. Its molecular formula is C3H6, discovered in 1881 by August Friend. Henderson and Lucas discovered its anesthetic properties in 1929. It inhibits NMDA receptors and also inhibits the AMPA receptor and nicotinic acetylcholine receptors. Cyclopropane superseded by other anesthetic agents due to its extreme reactivity. Cyclopropane oxygen mixtures are extremely explosive. Prolonged anesthesia patients may lead to sudden decrease in blood pressure and potentially leads to cardiac dysarrhythmia. A reaction is known as cyclopropane shock. Now coming to other inhalational anesthetic, that is diethyl ether. It is highly volatile liquid. Boiling point is 35 degrees Celsius. It is colorless, produces irritating vapors, pungent odor, inflammable and explosive. Pharmacokinetically, 85 to 90% of ether is eliminated through lungs, rest through skins, urine, milk and sweat. It crosses the placental barrier. Now coming to advantages of diethyl ether, it is simple to administer, no need for special apparatus, wide safety of margin, potent anesthetic agent and good analgesic agent also. It has good muscle relaxation properties, respiratory stimulation and bronchodilation. Does not need to sensitize heart to adrenaline, therefore no cardiac arrhythmias. Used in delivery patients, less chances of hepato or nephrotoxicity. There are also many disadvantages of ether. Recovery is very slow, inflammable and explosive, slow induction and unpleasant, breath holding, salivation and marked respiratory secretions which can be controlled by atropine as pre-medication to prevent the patients from drowning in his own secretion. Slow recovery rate and post-operative nausea and vomiting are seen. There are also cardiac arrest, convulsions in children and cross tolerance to ethyl alcohol. Halothane is the first fluorinated inhalational anesthetic agent which introduced in 1956. Halothane is fluorinated volatile liquid with sweet odor, non-irritant, non-inflammable. It is light sensitive, therefore it's supplied in amber colored bottle with thymol added as preservative. Potent anesthetic agent 2 to 4% used for induction and 0.5 to 1% for maintenance. Its boiling point is 50 degrees Celsius and it is volatile at room temperature. Pharmacokinetically, 60 to 80% eliminated in unchanged form and 20% retained in body for next 24 hours and metabolized by liver by cytochrome P450 enzyme. There are many advantages of halothane like potent and speedy induction and recovery, non-inflammable and non-irritant, sweet odor. It is suitable for inhalational agent for children, does not augment bronchial and salivary secretion, and also suppress pharyngeal and laryngeal reflexes and causes bronchodilation. Very low chances of post-operative nausea and vomiting, inhibits skeletal muscles, intestinal muscles and uterine muscle contractions. It can be used in obstetric purpose, but there are many disadvantages also, like special apparatus are required for administration, poor analgesic and muscle relaxation. That's why it is co-administered with nitrous oxide. Strong respiratory depressant, prolonged labor, decrease urine formation due to decrease in GFR. It is hepatotoxic, 1 in 1000, because of oxidatively metabolized in liver to tissue, and it converts into toxic hydrocarbons, that is trifluoroethanol and bromide ions. There are also strong cardiovascular depressant actions, it causing hypotension and arrhythmia. There are direct action on intracellular calcium ion and failure of sympathetic activity. It also causes arrhythmia, direct vagal stimulation, direct depression of SA node and lack of baroreceptor action. There are vagomimetic action causes atropine sensitive bradycardia, and it also causes malignant hyperthermia due to its action on ryanodine receptors. And the dantrolene sodium is used to treat malignant hyperthermia. Halothane interacts with adrenaline and theophylline, and it may precipitate arrhythmia. It is contraindicated in hepatic dysfunction. Now, next fluorinated inhalational anesthetic is enflurane. It is non-inflammable with mild sweet odor and boils at 57 degrees Celsius. It is similar to halothane in action, except it has better muscular relaxation properties. It depresses myocardial force of contraction and sensitizes heart to adrenaline. It is pro-convulsive in activity. It induces seizure in deep anesthesia, and therefore it is not used now. Lower metabolism rate as 1/10 of that halothane, and it does not release a significant quantity of hepatotoxic metabolite. Metabolism releases fluoride ion, which further causes renal toxicity. When talking to advantages of enflurane, it is less potent than halothane, produces rapid induction and recovery. Only 2% metabolized to fluoride ion, which is excreted by kidney, and also having analgesic activities. There is CNS excitation at twice at Mach and can induce seizure, and which is considered as major disadvantages of enflurane. Going further with fluorinated inhalational anesthetic agent, isoflurane is the next. It is commonly used with oxygen or nitrous oxide. It is isomer of enflurane and have similar properties but slightly more potent. Induction dose is 1.5 to 3% and maintenance dose is 1 to 2%. It administered by a special vaporizer. The main advantages of isoflurane are rapid induction and recovery, good muscle relaxation, good coronary vasodilation, less myocardial depression, and has no myocardial sensitization to adrenaline, no renal or hepatotoxicity, low post-operative or intraoperative nausea and vomiting, no dilatation of pupil and loss of light reflexes in deep anesthesia, no seizure, and preferred in neurosurgery. It has uterine muscle relaxation. The main disadvantages of isoflurane are pungent and respiratory irritant, special apparatus required for administration, respiratory depression, use for maintenance only, not for induction, beta adrenergic receptor stimulation, and costly. Now coming to next fluorinated inhalational anesthetic agent, which is desflurane, and it is commonly used for outpatient surgery because of its rapidity of induction and recovery. It is less volatile and it should be delivered by a special vaporizer. It decreases the vascular resistance and perfuse all major tissue very well. It is irritating and causes apnea, laryngospasm, coughing, and excessive secretions. Sevoflurane is another fluorinated inhalational anesthetic. which has low pungency and non-irritating. It is also suitable for children for operations, and it has rapid onset and recovery, metabolized by liver by releasing fluoride ion. Thus, like enfluorine, it may prove to be nephrotoxic. Sevoflurane is the second agent for choice for neuroanesthesia, cardiac anesthesia, and asthmatics. Sevoflurane reacts with soda lime and used in anesthetic circuit to form compound A, which acts as renal toxins, and using with soda lime it's converted into nephrotoxic agents. Agents should not be given with soda lime is trilene, sevoflurane, and desflurane because it reacts with soda lime. Methoxyfluorine is another fluorinated inhalational anesthetic agent, the most potent and the best analgesic anesthetic available for clinical use, but it is rarely used now because of its serious side effect because of nephrotoxicity, hepatotoxicity, low blood pressure, and malignant hyperthermia. In the year 2005, FDA has withdrawn it from the market. Now the hot topic for inhalational anesthetic agent is Genon. It is the anesthetic for future. Genon is a modern anesthesia gas. Its action close to ideal anesthetic. This gas is inert and is classified as a simple asphyxiant. Genon is a rare gas extracted from air. It is colorless, odorless, tasteless, heavy, and non-inflammable. Xenon provided rapid induction and rapid recovery due to its low blood gas partition coefficient 0.15 and Mach 1 of 63%, low blood and tissue solubility. That's why it causes rapid induction and rapid recovery. Xenon is very potent anesthetic agent, not metabolite. It has minimal side effects. Several in vitro studies showed that Xenon may protect neural cell against ischemic injury. It acts via non-competitive inhibition of NMDA receptors, and its toxicities includes inhalational in excessive concentration. It causes dizziness, nausea, vomiting, loss of consciousness, and death. It is rare gas and very expensive to produce. Now talking about toxicities of inhalational anesthetic agent, hepatotoxic is halothane, nephrotoxic is methoxyfluorine, proconvulsant is enfluorine, and the expansion of the trapped gases in the body cavity is caused by nitrous oxide. Malignant hyperthermia caused by all inhaled anesthetic agent except nitrous oxide. And the treatment of malignant hyperthermia is dantrolene sodium. Dantrolene sodium is directly acting muscle relaxant, and it acts on the ryanodine receptor 1 calcium channel in the cycloplasmic reticulum of skeletal muscles, which prevents calcium induced calcium release through these channels. Comparative characteristic of inhaled anesthetic agents: the partition coefficient, blood gas, brain blood, muscle blood, and fat blood. All in these four types of partition coefficient, nitrous oxide is having the lowest partition coefficient and the highest Mach value. This table also summarizes the difference between the inhalational anesthetic agents uh, under headings of minimum alveolar concentration, blood gas partition coefficient, rate of induction, amount metabolized, and amount of skeletal muscle relaxation. Where we can appreciate nitrous oxide has highest Mach value, then the rate of induction is desflurane and nitrous oxide and sevoflurane having the fastest rate of induction. This table also summarizes the difference between the inhalational characteristics of inhalational anesthetic agents, where we can appreciate nitrous oxide having the lowest airway irritation. There is no respiratory depression, no bronchodilation, no hypotensive effect, and no arrhythmia potential. Now summarizing further, nitrous oxide has unique side effect like irreversible oxidation of cobalt in vitamin B12, and prolonged exposure may cause peripheral neuropathy and megaloblastic anemia. Halothane, which sensitize the heart to arrhythmogenic effect of epinephrine, so that the dose of epinephrine more than 1.5 microgram should be avoided, and it is contraindicated in unexplained liver dysfunction and left ventricular dysfunction. Isoflurane is having pungent or ethereal odor. Coronary still phenomena may occur. Dilatation of normal coronary artery diverted blood flow from fixed stenotic lesions, and it is less attractive in pediatric use and CAD, coronary artery disease patient. Desfuran causing carbon monoxide poisoning, and before giving desfuran, check carbon dioxide absorbent if desiccated and replace. Sevoflurane excellent for a smooth and rapid induction, but it is very costly. And last, xenon is scavenged from the atmosphere, and it is having costly distillation. Thank you all for your attention. My next lecture will be on intravenous anesthesia and pre-anesthetic medication, and kindly subscribe my YouTube channel for further updates. Thank you.